A very good morning to all of you. First of all, I'd like to thank the Department of Pathology and Transfusion Medicine, Chettinad University, for organizing this virtual CME and workshop and for asking me to present me on this topic, antibody identifications. So moving on to this topic, a detailed approach to identify unexpected antibodies. Introductions. So unexpected antibodies can be classified mainly into two types, alloantibodies and autoantibodies. So alloantibodies react only with allogenic red cells that express the corresponding antigen, while autoantibodies are reactive with most reagent red cells as well as with autologous red cells because they typically target an antigen commonly expressed on all red cells. The general population, if you see, alloimmunization is estimated to be around as low as 0.5 to 1.5%, while in chronic transfusion recipient populations such as patients suffering from sickle cell anemia or thalassemia, it is considerably higher, around 10%. So determining the specificity of the antibody is the most important and most commonly used method for predicting its possible clinical significance in cases of blood transfusion. So this antibody panel is almost similar to an antibody screening, which was explained by the previous speaker. However, instead of 3-cell panel, we are having a 11-cell panel, which contains a defined number of antigens. These are all, most of them are clinically significant antigens. Before going into detail about this antibody identification, we have to know the factors which can influence the antigen expression, both on the reagent red cells as well as on the donor red cells. So first of all, the concept is zygosity and dosage, which was explained previously by the speaker. The reaction strength of some antibodies may vary because antibodies are more strongly reactive with red cells that possess a double dose expression of the antigens. And if you see, there are always variation in adults and units in the expression of these antigens. For example, cord cells contains small I antigen, while adult cells, if you see, capital I antigen is commonly present. Similarly, regarding storage, if you see Duffy antigens, they deteriorate more rapidly than others during storage. So only we see these antibodies may be very weakly reacting against stored reagent red cells, that is commercial red cells, rather than with fresh donor red cells. So incompatibleness will be strong with donor red cells compared to an antibody infection. Similarly, the age and nature of the specimen must be considered when red cells are phenotyped for antigens. Similarly, there are various factors which influence the antibody identification. Most commonly, in every blood center, we prefer a 11-cell panel. These commercial panels are accompanied by a common antigenic profile sheet, that is the antigram, which lists the phenotypes of the red cells. There are various test methods, of which tube testing is most commonly used. It offers most flexibility to test at different phases in antibody identification and the option to use a variety of additive solutions. Similarly, modern techniques like column agglutination technology and solid phase technology are less subjective, and they are having better workflow standardization. They enhance serological reactivity that may not be clinically significant in selection of units. That is one of the disadvantages in compared to CAT techniques, including the reactivity of warm autoantibodies. So these can interfere when we are finding out antibody identifications. The next comes the enhancement media and additive solutions. So low ionic strength saline, polyethylene glycol, and 22% bovine aluminum, all these play a role in the antigen antibody reaction. Similarly, anti-human globulin, what we use, whether it is a human IgG or a polyspecific reagent which contains anti-IgG and anti-complement. Because if you see some antibodies which are IgM in nature, they will fix complement. So you may need to see anti-complement coated AIG to identify these antibodies. First of all, before going in detail, we have to know the first and foremost is regarding the patient history. So first, we will be asking the history of red cell exposure, any history of transfusion, pregnancy, and abortion. Diagnosis of the patient is very important. Some diseases like infectious immunonucleases, mycoplasma, and cold agglutinin syndrome, we see the presence of anti-I. In paroxysmal cold hemoglobinuria, we see the presence of anti-P. In a lot of autoimmune disorders and stem cell transplantation. Similarly, medication and drugs such as intravenous immunoglobulin or RH immunoglobulin or monoclonal antibodies, they all can interfere in the antibody identification. Essentials in antibody identification. Whenever we are doing any antibody identification, some of the criteria we should follow. One is the auto control. This is done mainly to find out the presence of autoantibodies, or sometimes very rarely you can have these patients serum reactive to additive solutions, what we are using in blood bank. These autoantibodies, what is the main issue means they can mask clinically significant alloantibodies. So it's important to differentiate between autoantibodies and alloantibodies. Another test which is very important is direct antiglobulin test, DAT, in which transfusion history, autoantibodies or drug, all these can cause positive DAT. So in case of positive DAT, it can be either be an alloantibodies or an autoantibodies. So this is the panel we normally use, a 11-cell panel, in which we use at 3 different phases. This is very important: immediate spin phase, a 37-degree phase, and AG phase. So why we use these 3 different phases? Because each antibody can act more commonly at one particular phase, which will be able to helpful to distinguish between the antibody and to find whether it is clinically significant or not. How we are going to interpret these results? So antibody reduction results are interpreted as positive or negative according to the presence or absence of reactivity. There are a few basic steps which we should follow while interpreting panels. One is ruling out, that means crossing out antigens that did not react. The second is circle the antigens that are not crossed out. The third is consider the antibody usual reactivity. And the fourth is look for a matching pattern. These are the 4 steps we should follow when we are going to identify any antibodies. So coming to the first step, that is ruling out. As you know, in the antigram, all the antigens which are expressed are given as positive and which are not expressed are given as 0. So we do the antigram testing for the 11-cell panel and we get various reactions. So in this particular case, here the reaction you can see the cell number 1, cell number 4, cell number 7, and cell number 9. The remaining all are negative, clear-cut negative: 2, 3, 5, 6, 8, and 10 and 11. So the main thing is we are going to cross out antigen that shows no reaction in any phase. So wherever the reaction is 0, we'll be crossing out the antigens. The one thing we have to go not forget is do not cross out heterozygous antigen that shows those. So by crossing out, we'll be able to remove many of the antigens. After we have crossed out, there occurs only the very few antigens. We circle the antigens which are not crossed out. Here in this antigram, you can see almost all the antigens have been crossed out except for 2 antigens, that is capital E and Louis A. The third step is consider the antibody usual reactivity. That is, if you see these 2 antibodies, if you see these, they act more at an immediate spin phase rather than at 37 degrees Celsius and AG phase. And you see this Louis antibody is more an IgM type of an antibody, which has more capacity of working, reacting at immediate spin phase. However, this E antibody, capital E antibody, is supposed to be an IgM antibody, which you expect to see in a AG phase. So this by which we can deduce that the probable antibody is Louis A. The final step is look for a matching pattern. So wherever you have seen this agglutination in each cell panel, you compare whether that antigen is correspondingly present or not. If you see in the cell panel 1, cell panel 4, cell panel 7, and cell panel 1, the antigen is present and consequently some reaction has happened. However, if you see capital E, the antigen is not there, but the reaction has happened. So since there is a matching pattern, we can confirm and say this is a Louis A antibody. These are the 4 steps we should follow when we are doing any antibody identification. So the probability of accurate identification. So we are having a probability standard. A standard approach, that is Fisher exact method, is requires that 3 antigen positive red cell samples are reactive and 3 antigen negative red cells are not reactive for each specific is identified. So you need minimum of 3 to say this is the antibody causing the discrepancy. A more liberal approach of 2 reactive and 3 non-reactive red samples, or with 1 reactive and 7 non-reactive red samples, also can be done. The confirmation is done and the patient result should lack the corresponding antigen. So we should do the phenotype so that we deduce to know that the patient does not have the antigen. So in our previous study, previous case, we saw that there are 3 positive cells. So 3 positive cells, there are also 3 positive reactions there. Panel cells 1, 4, and 7 are positive for the antigens and gave a reaction, while panel cells 8, 10, and 11 are negative and does not give a reaction. Similarly, we can use also selected red cells for exclusion and confirmation. Selected red cells are chosen from other panel or screening cells to confirm or eliminate the antibody. The number of selected cells needed depends on how many antibodies are identified. So selected red cells, they are chosen for the specific antigen they carry or lack, are used to confirm or rule out the presence of antibodies. these red cells ensure that non-reactivity with the selected red cell sample indicates the absence of that particular antibody. So we can take some selected red cells and check for whether the antibody is working against that or not. So in this example, you see this patient has been suspected of having 3 antibodies, capital S, JK, and P. So what we have done is we have taken 3 selected cells, 158, and each cell has got only 1 antigen present and the remaining 2 are absent. So when we run this test and find out, we see the reaction is happening only in cell panel 1 and 5, which contain capital S and JK. The cell panel 8, which contains the P antigen, is giving a 0 reaction. So we can tell instead of 3 antibodies, there are actually 2 antibodies present, capital S and JK. So this antibody identification becomes very simple whenever it is a single common alloantibody, because the single common alloantibody usually produces a very clear pattern with antigen positive and antigen negative reagent red cells. Exclusion of other antibodies must be performed to ensure proper identifications of the antibody potentially present. So we can also do additional investigations mainly. One is abbreviated identification panel. That is, if the patient has antibodies that were previously identified, so we can use the known antibodies should be considered when selecting reagent red cells so that they do not cross-react. So since already the antibody has been identified. Similarly, determining the phenotype of an individual autologous red cells by serology or genotyping is an important part, because we know the patient red cells are expected to lack antigens to which they make any alloantibodies. If the patient red cell phenotype is known, reagent red cells may be selected to detect only those alloantibodies that the patient would potentially form. The next we move across is complex antibody identification. This can occur mainly because of various issues. One is multiple antibodies, warm autoantibodies, cold autoantibodies, antibody to high prevalence antigen, and other causes. So these all things can make it a very complex situation to identify these antibodies. Coming first to multiple antibodies, we see the observed pattern of reactive and non-reactive red cells does not finger a single antibody. You think the more antibodies a sample contains, you expect a more complex identification and exclusion becomes a little difficult. And the second important thing you can see is reactivity will occur at different test phases. That is, you can see one reactivity at room temperature and another reactivity at IATP, which tells that 2 antibodies are acting at 2 different phases. And the third thing is the unexpected reaction can occur when attempts are made to confirm the specificity of a suspected single antibody. So you get a lot of cell panel which is giving positive reactions. If you take a phenotypically similar panel red cells, it will be non-reactive. That means it is not an autoantibody. A phenotypically similar red cell is one that lacks the same common antigen as the patient red cells. So lack of reactivity with these type of red cells indicate the alloantibody are directed against common antigen which is lacking from the test red cell. That means it is not an autoantibodies but a case of multiple antibodies. The second issue we can come across is reactivity which is happening without any specificity. So the reactivity of the serum is very weak. The pattern of reactivity and the crossout process has excluded all likely specificities. Alternative approaches should be done. So alternative test measures such as enzymes, dithiothiotol, absorption elution should be done. So which I will be discussing in the coming slides. And the main thing, one of the things, unlisted antigens. So what happens means a sample may react with a red cell having antigen that is not listed on the antigram, that is on the antigen profile supplied by the reagent manufacturer. So we are having around clinically significant antigens. So unlisted antigens, the antibody can consequently react, which cannot be picked up. The sample may be reacting with many or all of the group O reagent red cells, but not with red cells of the same AB group. This is another issue we can see. That is, screening cells are reactive, but donor red cells, if you do cross matching, is compatible because mainly the anti-H or anti-high H antibody, which will react with the group O reagent red cells, but will not react with any donor A or B cross match compatible cells. Another issue is inherent variability. That is, you can expect some nebulous reaction patterns that do not appear to fit any particular specificity or characteristic of certain antibodies, such as Bennett speed antigen or anti-NOX. Next, we move to warm autoantibodies. Warm autoantibodies is a very large chapter. So I'm just covering just a simplified aspect. So the presence of warm reactive autoantibodies in a patient's serum creates a special challenge because the antibody will be reactive with whatever red cells we are testing it. The majority of warm autoantibodies are IgG, and the patient with warm autoantibodies require a transfusion. It is important to detect any underlying clinical significant antibody. This is the one which is very, very important. This warm autoantibodies may mask clinically significant antibodies. So when we are using enhancer media, the polyethylene glycol enzymes or low ionic strength saline, they may enhance these autoantibodies, and we have to be very, very careful when we are using enhancer media. So only we see tube, it will be a compatible, but when you are doing a gel technique, you can get an incompatible reaction. That may be cause of an autoantibody playing a major role in CAT techniques. And we need to omit this enhancer media when we are suspecting that any warm autoantibodies are present. The other autoantibodies is the cold autoantibodies. Potent cold autoantibodies that react with all red cells at room temperature or below, including the patient's own, can create special problems, especially if the reactive process of the IAT phase of the antibody identifications. So gel column test can give a mixed field appearance even though only one cell population is present. If you see, the goal in most situations is to circumvent or remove the interfering cold autoagglutinin reactivity in order to detect underlying and potentially clinical significant. Same issue can occur. The cold antibodies can mask a clinically significant antibody. So it's better to choice is use of anti-IgG rather than polyspecific IgG, because IgM antibody, most of the cold antibodies are IgM, and these IgM antibodies can activate complement. So if you are using a polyspecific, it can cause a cross-match incompatibility. So we have to omit the room temperature as well as immediate spin phase of testing, because these cold antibodies has more chance of reacting at 4 degrees Celsius and 22 degrees Celsius. So cold or auto or allogenic absorption of the patient's serum also can be done to remove these cold autoantibodies. And pre-warming techniques we can do, whether the patient's serum, the reagent red cells, the entire test tube or the plasma are pre-warmed, and then the procedure is done so that these cold antibodies get disappeared. Another we come across is delayed serological transfusion reactions. So delayed transfusion reactions are defined by the development of a new allo antibody in a patient following a RBC transfusion that results in lab evidence and clinical evidence of destruction of incompatible transfusion red cells that were compatible at the time of infusion. So this occurs after a compatible transfusion has been done. So the patient has received transfusion in the last 3 months and the autocontrol is positive in the IAT phase. There may be antibody-coated donor red cells in the patient circulation, resulting in a positive DAT result that can show mixed field reaction. So when we are getting any positive DAT, we may have to suspect delayed serological reactions. So an elution should be performed so that when tested on plasma or serum or inclusive. Sometimes in the serum, the plasma, the antibody may not be present. So elution can be done so that the antibody which is coated on the red cells can be removed and tested. Next is antibodies to high prevalence antigen. If all reagent red cells are reactive in the same test phase and with uniform strength, but the autocontrol is non-reactive, an allo antibody to a high prevalence antigen should be considered. So you have a very uniform strength, but the reaction is happening in the all reagent red cells. So antibodies to these high prevalence antigen will be accompanied by antibodies to also common antigens. Some of the clues to identify this is reactivity will occur mainly at room temperature, suggesting the presence of antibodies such as anti-H, anti-I, anti-IH, and reduced or absent reactivity with enzyme-treated red cells occurs with any Chiro-Rogers antibody if you are suspecting, and weak nebulous reaction in the IAT phase. So we get maximum of a 1+ reaction only. You don't never get a strong reaction in the IAT phase. So there was also a list of other causes which can cause a complex antibody identification. One is the drugs. Drugs which is being intaken by the patient can induce the formation of antibodies, and these drug-dependent antibodies may cause positive antibody identifications at the IAT phase and at the positive DAT results. So prompt correlation between clinical course, drug history, and serological finding gives opportunity for timely recognition of the event. So antibodies to a variety of enhancing media used in testing reagent can cause positive reactions in antibody identification. Similarly, they are in vitro phenomenon and have no clinical significance in transfusion therapy. Rouleau formation is also another in vitro phenomenon that is produced by abnormal patient serum protein concentration. So we can use a saline replacement technique to detect the presence of rouleau. So these are a list of other causes which can interfere when we are doing antibody identification. So what are the alternative methods we can do to resolve these problems? One is enzyme treatment, chemical modification, inhibition technique, absorption, elution, or combined absorption and elution. So we'll be seeing all these things. First of all, available methods. So any blood center which we have to try with the whatever available methods we are doing to resolve this problem. So we can use enhanced media. So most of the blood centers are having LIS or PEG additive. So using this will reduce the incubation time and also will enhance reactivity. One of the main issue, as I told you before, can enhance the autoantibodies, which can complicate any alloantibody findings. Similarly, temperature reduction favors some antibodies. So if we see this anti-M, anti-N, you can see it reacts at a lesser temperature. An increased serum to cell ratio, increasing the volume of serum incubating with the standard volume of red cell may enhance the reactivity of antibodies that are present in low concentrations. Similarly, titration, it provides information about the relative amount of antibody present in a sample or the relative strength of antigen expression on the red cells. And titration used in prenatal studies, this also will be helpful to find out the strength in a pregnant woman. And similarly, high titer low avidity antibodies. So these will have a very high titer, that is more than 1000, but the reaction phase, if you see agglutination, will be very less, 1+ or weak agglutination. We see in Chido, Rogers and Notes. So these are some of the things we can do to resolve with the available methods what we are having in blood bank. The most important thing is enzyme treatment, and it is very easy to do to resolve this complex antibody identifications. So this enzyme can be used to enhance or destroy certain blood group antigens. Several enzymes exist. Physin prepared from figs, bromelain from pineapple, papain from papaya. So this enzyme removes the sialic acid from the RBC membrane and destroying it and allowing other antigen to be enhanced. So it destroys something and it enhances some antigens. So antigens which are destroyed are M, N, S, small s, and Duffy. Antigens which are enhanced are RH, KIT, Lewis, and INP. So if there is no agglutination after treatment, then we can assume that the enzymes have destroyed the antigen and hence the reaction is absent. So in this example, we see they have done a reaction with the cells, and if we see almost all the cells except cell panel 3, 7, and 8, all the cells are given some reaction, strong reaction. And if you look at the compare with the matching pattern, only Duffy A matches with that. But the capital K also cannot be ruled out. So what we do means we do with the Physin treatment. So when we do with Physin, this Duffy A antigen is destroyed. So we get a 0-0 reaction, I mean negative reaction in all the things, but you get 2 reaction in cell panel 4 and 6. Then when we check, the presence of K antigen is revealed. So hence we can confirm that not only Duffy A antibody is present, but also anti-K antibodies are also present in this particular patient. So enzyme treatment will help to resolve many of these issues. And when they have done the patient RBC, they are found to be KL negative and Duffy A negative. So another issue is chemical modification of red cells and antibodies. So we can modify red cells as well as we can destroy some antibodies. So sulfidal reagents such as 2-aminoethyl bromide, 2-mercaptoethanol, and dithiothriotol. So these reagents, they cleave disulfide bonds that are responsible for the conformation of certain blood group antigens and therefore can be used to weaken or destroy antigens in the KL system. Similarly, sulfhydryl reagents such as dithiothriotol, 2-mercaptoethanol can be used to cleave the disulfide bonds that join the monomeric subunits of the IgM pentamer and help differentiate between IgM and IgG antibodies. We can use ZAP reagent, which contains both the proteolytic enzymes and dithiothriotol. They denatures antigen that are sensitive to dithiothriotol, that is KL system, as well as antigen that are sensitive to enzymes. So this we can use a combination. While if we want to differentiate between IgM and IgG, we can use these sulfhydryl reagents. Next is inhibition techniques. So we see some soluble substance present. They can be used to inhibit the reactivity of the corresponding antibody that could mask the presence of any underlying non-neutralizable antibody. So we can use inhibition technique to inhibit one particular antibody. So inhibition of the reactivity by a soluble substance can help with the identification of the specificity of the antibody. So we can also identify specificity by using this inhibition technique. So most commonly we see Lewis antigen present in the saliva of the individual. You can use the saliva as an inhibition medium. Similarly, soluble P substance is present in hydrated fluid and oval albumin of pigeonhole. So these are all mediums by which we can inhibit that particular antibody and resolving the identification. The next most commonly used is an absorption. So absorption is nothing but antibodies can be removed from a serum sample by absorption onto red cells that express the corresponding antigen. So we can remove the cells by absorbing onto red cells. So after the antibody attaches to the membrane-bound antigen, the antibody remains attached so that the serum and the plasma are free from that antibody. So separating multiple antibodies present in a single serum So we can remove the autoantibody to permit the detection of any underlying alloantibodies. And also we can use it to confirm the specificity of an antibody by showing that it can be absorbed onto it. So all these can be used to find out by using absorption. To ensure that the absorption process is complete, that is, that no unabsorbed antibody remains, it is essential to confirm that the absorbed serum is non-reactive with a sample of the absorbing red cells that was not used for absorption. So we have to always be careful that absorption process is completely over. That is, all the antibody has been absorbed so that the subsequent reaction can be done clearly. So here you can see there are mainly two types of absorptions. The one is the auto absorption. That is, we are using the patient red cells to remove existing autoantibodies, 3 times incubation. Then we are keeping it for 30 to 60 minutes to remove autoantibody and test for alloantibody. The second thing is allogenic absorption. That is, we are having separate test tube. We are incubating the patient serum with 3 different phenotype red cells. So we are having one red cells being phenotype, and then we are adding the antibody, knowing that if the antibody is present, consequently that antibody will be absorbed. The next thing which we can use to other than absorption is elution. So elution, it dissociates the antibody from the sensitized red cells. These bound antibodies may be released by changing the thermodynamics of antigen-antibody reactions, neutralizing or reversing forces of attraction that hold antigen-antibody complexes together, or disturbing the structure of the antigen-antibody binding sites. So different type of elution methods are there. Heat or freeze thaw elution is there. Techniques are usually restricted to investigation HDFN caused by avian compatibleness, or acid of organic solvent methods. Glycine EDTA solution are used for eluting warm reacting antibodies, auto or alloantibodies. So elution should be done whenever DAT is positive. So when you do an elution technique, it frees the antibodies from the sensitized red cells. So these antibodies are present in the eluvate, and these eluvate can be tested further in the antibody intubation so that we'll be able to get a clear reaction. Sometimes we can combine both absorption and elution. That is, the process consists of first incubating the serum with selected red cells and then eluting antibody from the absorbing red cells. So the care must be taken when selecting the absorbing red cells to separate a mixture of antibodies. The cell should express only one of the antigens corresponding to an antibody in the mixture so that the eluvate from the cells will contain only that antibody. So it is mainly used for separating a mixture of antibodies in a single serum sample, detect any weakly expressed antigens onto red cells, and help identify weakly reactive antibodies. So whenever we are using absorption elution, we have to make sure that is properly QC has been done so that we don't miss any kind of antibodies. So when we do all these techniques, so what is the ultimate results? We have to find the significance of these identified antibodies, whatever unexpected antibodies are there. So the phases in which an antibody is identified and its specificity are the two important means to predict an unexpected antibody's potential clinical significance. So if you see antibody that react at 37 degrees Celsius or IAT phase are very clinically significant. Antibody at reacting at room temperature and below are supposedly non-clinically significant. But very rarely you see anti-well and anti-P. These antibodies which can react at cold temperature, but they may also cause red cell destruction in vivo. Similarly, Chido-Rogers antibody, which have little or no clinical significance despite their reactivity in IAT. So all these issues has to be taken into account. So how we are going to select these donor units? So RBC unit selected for transfusion for patient potentially clinical significant antibody should be negative for the corresponding antigen. Even if the antibodies are not detectable in the serum, but the mention of the antibody is there, all subsequent RBC transfusion to the patient should lack the antigen to prevent a secondary immune response. This is very important so that any blood center which has detected an antibody, that information has been conveyed to the patient so that in case of future transfusion, we may be careful. Similarly, antibodies which are very clinically insignificant, it's better to go for serological compatible units instead of wasting time in doing a rigorous process of antibody identification. And finally, we can always go for a phenotype matched blood. That is selecting the RBC unit that are phenotypically matched with the patient for clinically significant antigen when the patient has a potent warm autoantibody. So in case of chronic transfusion therapy like sickle cell disease or thalassemia, we make sure that antigens, the phenotype matching is done. There's absence of capital C, E, and K antigens. So in case of a rare blood units, so rare blood is nothing but the units which are negative for high prevalence antigen, that is 1 in 1000 units, or negative for a combination of many common antigens, that is less than 1 in 100. So to calculate this the rare blood units, we need to say the prevalence of the compatible donors for patients who have multiple antibodies. One must multiply the prevalence of the donors who are negative for the one antigen by the prevalence of donors who are negative for each of the other antigens. So it's just a multiplication whereby we'll be able to calculate that how much units we need to cross match to find a compatible rare unit. So autologous RBC transfusion also should be considered for patients with rare phenotypes who are expected to be bled in the future. So it's a very simple calculation of calculating the prevalence of compatible donors. For example, like a group O patient serum contains small c, Duffy and capital S needs RBC transfusion. We are going to calculate the prevalence for each of these negative individual, antigen negative individual. For example, C negative individuals is 18%, Duffy A 34%, and capital S is 45%. So we are calculating 0.18, 0.34 to 0.48. And then what we do is we have to find AB compatible donors. Since it's a group O donor, 45% are group O, then we multiply this 0.45 into the 0.08. We get is 0.013, that is 1.3%. That is 1.3% of the general population would be a compatible donor for a group O patient who is having small c, Duffy A, and capital S. So coming to the conclusions, if you see common clinical significant antibodies that should be considered in the process of exclusion during antibody identification or capital D, capital C, capital E, small c, small e, MNS, small s, capital K, small k, Duffy A, Duffy B, JKA, JKB. So these are some of the clinical significance. We have to be beware of that. And based upon probability, the use of 2 reactive or 2 non-reactive normal procedures, 3 reactive and 3 non-reactive red cells have for acceptable for antibody confirmation. And finally, the presence of autoantibodies, whether it's a warm autoantibody or a cold autoantibody, multiple antibodies and other causes can result in difficulty in identifying the unexpected antibody. Always go for alternative methods. Make sure that it is available in your blood center, whether it's enzyme treatment, chemical treatment, absorption, elution, which helps to distinguish and identify the specificity of the antibody. So the ultimate goal in antibody identification, if you see, is not only in identifying the specificity of the antibody, but also we have to ensure the availability of the safe and compatible blood to the patients. So reference ABB Technical Manual 20th edition. So the list of the procedures and various techniques are given. So those who want to go through can see that. I thank everyone for kindly and patiently listening to me. Thank you very much.